Hello and welcome back to the channel. You've joined myself, Dr. James Gill, for another clinical skills video. Today we're going to take an in-depth look at one of the most classic and high-yield murmurs in cardiology, the murmur of aortic stenosis. This is high yield for a reason. It's the most common valvular heart disease, with an estimated 2% of 65-year-olds affected. By the end of this video, you should understand not only what it sounds like, which is basic clinical examination knowledge, but also why it sounds that way and how you can detect it confidently during your cardiac clinical examination. So, first up, what is aortic stenosis? If we want to understand something, first we need to be able to properly define it. So, I'm going to ask you to pause this video and think of how you would answer the question in a clinical exam: what is the definition of aortic stenosis? Then hit the play button again and we'll carry on. So with the magic of YouTube, I'm assuming that we've done that. So how would I diagnose or make the definition of aortic stenosis? I would say that aortic stenosis can be defined as the narrowing of the aortic orifice, most commonly due to the aortic valve thickening or narrowing, which results in obstruction for the left ventricular outflow during systole, with a potential for symptoms secondary to that reduced cardiac outflow and the need for the left ventricle to generate greater pressures to overcome the resistance due to the aortic orifice narrowing. Now, as an aside, for any of your examinations, if you're not sure what to write or say when you're asked for a definition question, keep in mind that definition requires three things: the term you're discussing, the category in which the term belongs, and the differentiating characteristics from other members of the class. So here we've said our term is aortic stenosis, and we're characterizing it as a narrowing of an orifice, which we're further subcategorizing as the cardiac orifice and differentiating it from other similar cardiac stenoses by highlighting that it will also affect the left ventricular outflow. Hopefully that makes sense and will stand you in some good stead should you have other definition questions you need to answer. So the next part of having a chat about aortic stenosis has got to be the etiology of aortic stenosis. Essentially, we can divide the answer to this into three major causes by age group. The commonest cause is just age-related calcific degeneration of the aortic valve. As we've said, we know that aortic stenosis affects 2% of the over 65 age group. The calcific degeneration is going to account for about 50% of all age-related cases. So staying with our definition, that kind of makes more sense, because as the valve becomes more calcified, it becomes hardened. So it can't open as wide, and the calcification also causes thickening, which is going to narrow the already restricted opening of the valve. So hopefully you can see that age is a crucial thing for building up calcium, for making the valve less mobile, and subsequently making it thicker. The next cause of aortic stenosis is going to be congenital issues. So for example, bicuspid aortic valves, they're going to have a much greater risk of age-related calcification, so it's going to result in earlier narrowing, and hence those symptoms are going to typically occur in a younger age group, say 40 to the 50-year-old age group. We can also have issues with the unicuspid aortic valve, an even worse congenital defect, and that's demonstrated by the fact it would typically present with problems in the newborn or in the infancy of a child. The final big set of causes of aortic stenosis is going to be rheumatic heart disease. Frankly, this is more of a medical school answer as opposed to a real-world answer, and that's because rheumatic fever, and crucially the post-inflammatory effects of rheumatic fever, are now very infrequent / rare. So in terms of strep throat, etc., that can cause this, there's less than 1 in 100,000 cases will develop rheumatic fever, and even fewer of those will develop the cardiac complications associated with developing valvular heart disease. So it happens, but now we've got antibiotics which we're throwing around left, right and centre. Not a high probability. Yes, there's also a smattering of even rarer causes such as infections, lupus, etc. But these are less relevant in day-to-day practice. Now, to be fair, rare does still occur. When I was working as a vascular surgery junior doctor, I had a patient with infective endocarditis secondary to lifestyle actions which resulted in bacteria growing in his heart and on the valves, resulting in narrowing of the aortic valve and subsequent complications, all leading to an aortic stenotic murmur. You could really hear his murmur, and I think part of that was because of the severity of the infection which had damaged the valve and the leaflets that had formed on the valve. So that's the etiology of aortic stenosis. But what about the pathophysiology? How does aortic stenosis affect the body? The short answer here is that aortic stenosis causes hemodynamic changes. But if you give that answer to your consultant, their response will probably along the lines of "that's correct, but give me more detail." It's very easy to try and fob people off with answers like that, but you're probably not going to get away with it. So in terms of that more detail, what are we going to say? It all comes down to pressure. So if you take your fingers and try to blow through it, there's literally no resistance. Now make that circle smaller and try to do the same again. It's a little bit harder because we've got a narrowing of the orifice. To keep the same flow, I've got to work a bit harder. I've got to increase the pressure. Now, if I make that circle even smaller, you're going to see your cheeks blow out because you can't push the same flow through that narrowed opening. What you've done here is demonstrated an increase in afterload. And I go back to the fact that what is the pathophysiology of etiology? It's all about hemodynamics. So with the narrowing, we have an increase in afterload. Cardiology, heart murmurs, we see an increase in afterload due to narrowing of the aortic valve, meaning the left ventricle has to pump with greater force to overcome that resistance. That is the core of understanding stenotic murmurs. Wherever the narrowing is, the heart is going to have to work harder to overcome that narrowing, i.e. that narrowed valve increases the afterload. Thus, as we've said, the left ventricle has to generate a higher pressure to maintain the cardiac output. Now, because the ventricular muscle is having to work harder to maintain that systolic function, the body is going to adapt and we're going to see cardiac remodeling. This will lead to left ventricular hypertrophy. Now, for want of a better phrase, this is where the wheels start to come off. Because you've got an increased size or bulk of the left ventricle muscle, we've now got less compliance. What does that mean? It's harder for the left ventricle to expand. As a result, you're now going to get a diastolic dysfunction. So not only is the heart having to work harder to maintain the systolic function, but that increased muscle mass is less efficient, meaning there's a greater increase of heart failure. So we understand the etiology, we understand the pathophysiology of aortic stenosis, but where does the actual murmur come into this? How do we get the sound? I can't tell you why, but this is how I've always thought about it from medical school. When blood is travelling through a blood vessel, we've got laminar flow. All the blood is flowing in the same direction in an ordered fashion, and there's very little resistance against the blood vessel wall. As a result, there's relatively little noise. If we have a complication, so for example a narrowing, let's just put a kink in the blood vessel wall. That's going to increase the turbulence at the blood vessel wall, and now we're going to start getting noise because we no longer have that laminar flow. Why does a turbulent flow generate sound? Because that turbulent flow causes vibrations as the blood is literally hitting the blood vessel walls, and those vibrations we can hear with the stethoscope as a murmur. So that's what murmurs are all about. Essentially, it's turbulent flow. Hence, when we're grading a murmur, the greater the sound, the greater the strength of the murmur. So we associate a greater severity of a murmur with a louder murmur. Although there is a small caveat here. When we've got a higher flow state, that will also enhance the sound generated by a murmur. So, for example, if you ask a patient to exercise, the ejection systolic murmur, for example, of aortic stenosis, would increase. Why? Because we're asking for a greater output, so that's going to increase the turbulence of that flow further. And all of that will lead us to some of the clinical symptoms of aortic stenosis. So, keeping in mind, everything is going to relate clinically to hemodynamic instability. Due to the cardiac outflow narrowing and the heart muscle remodeling, a patient's heart might have a fixed cardiac output at rest, but with no clinical symptoms. What that means is, at rest, they're able to have a sufficient cardiac output that it doesn't cause them any problems. But if they try to exercise, because they have a fixed cardiac output due to the left ventricular hypertrophy and the aortic stenosis, they're not able to increase their stroke volume if they were to try to exercise. Thus, there's not enough blood going out to supply the body. Thus, we might end up with loss of consciousness. We might end up with syncope. So let's stay with that idea that they can't increase the cardiac output as needed. Because they can't increase their cardiac output, that means that they're not able to respond to an increased oxygen demand. So, for example, from the increased muscle mass of the left ventricle due to the hypertrophy. That's important because patients with aortic stenosis may develop angina because they try to exercise, they can't get the sufficient coronary artery flow, and thus you get pain and hypoxia of the cardiac muscle. So as we get increasing left ventricular hypertrophy, that can also lead to a diastolic dysfunction, as we mentioned earlier, because it's harder for the chambers of the heart to relax and thus fill up. That then leads to a potential increase in pulmonary pressure, causing shortness of breath, causing dyspnea. Now, that might just be a mild inconvenience for the patient. However, as things progress with regard to the left ventricular hypertrophy, we may actually get pulmonary edema because of a left heart failure, and that's going to have a much bigger impact on that shortness of breath or dyspnea. So you can see we've talked there about the classic triad of aortic stenosis. We've got syncope, angina, and dyspnea, so SAD. As a memory aid, we could literally say that patients with aortic stenosis are sad because they've got syncope, angina, and dyspnea. Sometimes medical school isn't as complex as we think it is. Now, it's possible that the patient with aortic stenosis may be asymptomatic until they're late in the disease. Hence why it's very important when you're doing your basic clinical checks, for example with a patient who's got hypertension, that you do, when appropriate, auscultate the heart. You don't skip things and miss corners, because this simple examination might identify the critical issue of an ejection systolic and aortic stenotic murmur early and potentially allow for early intervention. Now that's really important, as survival drops off rapidly as we develop symptoms. For example, if a patient with aortic stenosis has developed angina, the survival rate from that diagnosis is about 5 years. If they're getting syncopal episodes, that can be down to 3 years. And heart failure, which is our biggest complication here, from a survival perspective, without intervention, these patients can potentially die within just 2 years of diagnosis. So this is really, really key in terms of patient survivability. So the question's got to be, how are we going to make that diagnosis? With regard to the clinical skills, remember that all examinations start from the end of the bed. So just using our eyes, what do we want to look for? Signs of heart failure, realistically, because we've highlighted that that's the worst part from a survivability perspective. We're probably not going to see evidence of syncope, but we might see a patient sitting there with breathlessness, but that's also going to connect with heart failure. So we're going to look for breathlessness, evidence of peripheral edema. We might see issues with pallor, for example, due to low cardiac output, and we might even see slow movements because the patient is subconsciously adapting to their inability to increase their cardiac output. Then when we expose the patient, we want to have a look at their chest, and we want to see if we can see previous evidence of surgical scars. So for example, a midline stenotomy, which might indicate that they've already had cardiac, at least, surgery. That's very important because previous valvular surgery is a high risk for valvular complications down the line. With all of these things, we're thinking, is there anything that might make our brains go, think about a potential valvular pathology here? So, looking at the vital signs, when we measure the blood pressure, we often focus generally day to day with blood pressure about diagnosing hypertension. But looking at the pulse pressure is a very, very important step. If we have an aortic stenosis, that patient might have a low or narrow pulse pressure, i.e. the difference between the systolic maximum and the diastolic minimum might be quite little. This is because of an obstruction to the heart outflow, literally meaning that the systolic maximum is decreased and the left ventricular hypertrophy, with that inefficient contraction that we've spoken to, and that's decreased flexibility to the heart wall, is going to reduce the compliance, meaning we get an increased diastolic pressure. Now, normally you'd expect a pulse pressure of about 40 millimeters of mercury in a healthy patient. In a patient with significant aortic stenosis, this might be a much smaller difference, as low as 25 millimeters of mercury in a very serious stenosis. So given the issues are all focused on cardiac outflow impairment, we might also see a raised pulse rate, because essentially the heart's having to do more beats to try and compensate for that outflow. Similarly, assessing the rhythm is important, as aortic stenosis can potentially be complicated by atrial fibrillation. Why? Because we're ending up with that left ventricular hypertrophy, we've got that cardiac remodeling, and often that can be disordered, ending up with electrophysiological problems such as atrial fibrillation. Now, we also want to check the character of the pulse. When we do so, we might find a slow rising pulse or a low volume pulse, depending on how you want to play it. This makes sense because if we think about the resistance in producing the normal systolic ejection through that narrowed aortic valve, for want of a better phrase, a reduced stroke volume, because we can't get as much out, and that's going to lead to a lower volume in the pulse. I hope that one makes sense. So moving away from the vital signs, we're now going to actually start looking and poking and prodding the patient. So with regard to abnormalities of aortic stenosis, there might be a few things that we can pick up when we palpate the precordium. If we place a hand over the left sternal border, we might feel a cardiac heave. Now, it's important to highlight this is a powerful lifting sensation of your hand due to the increased muscle mass of that left ventricle. It can be felt over the left sternal border, but potentially over the apex beat as well in some patients. As that left ventricular hypertrophy worsens, in severe cases, over the aortic area, that being the right second intercostal space, you also might feel a thrill due to the turbulent flow caused by the aortic stenosis. And I think that's really, again, highlighting the severity here. We've gone from a turbulent flow causing a sound to now a turbulent flow causing a thrill, a palpable murmur, just due to changes in blood flow. So moving away from the thrill, which, let's be fair, is not a common finding, we're going to pick up the stethoscope and try auscultating for the murmur. When we try to listen to the murmur, we need to pay attention to some specific criteria, or at least keep in mind criteria to speak to our consultant. That being, what's the site of the murmur, the character of the murmur, the timing, the radiation, and the intensity of the murmur, and as well as do we have any additional sounds such as changes to the valve heart sounds anyway. So for example, in aortic stenosis, the site will be loudest in the aortic region, so the right second intercostal space. The character will be a harsh sounding ejection systolic murmur, which when we graph it, it has a crescendo decrescendo or diamond shaped pattern. The intensity is certainly going to be important to comment on, but not specifically characteristic of an aortic stenosis. What we're meaning is, how loud is the murmur? Can you just barely hear it with a stethoscope, or is it potentially something you can hear actually without even putting the stethoscope on a patient's chest? Now that becomes relevant with regard to aortic valve replacement. So replacement might cause a grade 6 murmur. So what I'm meaning there is that you'd have an audible click, because you can hear the metallic leaflets of the replaced aortic valve clicking together, even without a stethoscope. And it's quite bizarre when you're talking to a patient and you can hear this throughout the consultation and know that that's the valve in their chest making that noise. Going back to the criteria, the timing of the murmur, as we said, should be ejection systolic, and the radiation of an aortic stenotic murmur would classically go to the carotid arteries in the neck. In terms of additional sounds, it's possible that we might have an ejection click just preceding the murmur. Now that's going to be loudest with the diaphragm at the second right intercostal space, or potentially also at the apex, and it's due to the aortic cusps opening because the valve has become calcified, so we're now getting a click that we didn't get before. But it's also possible that we might have an absent second heart sound again as a result of this, all due to that limited cusp motility. We appreciate that when it comes to clinical examinations, often we need to have the patient do certain clinical manoeuvres. With aortic stenosis, the murmur is increased by getting the patient to squat or engage in the Valsalva manoeuvre. Now, if that's not possible, we can get the patient to squeeze our fingers as tight as they can. That will have an effect of adjusting the intrathoracic pressure and softening the severity of the aortic stenotic murmur. But the question is, why? So if we find a way to increase the intrathoracic pressure, it's going to help us diagnose aortic stenosis and crucially differentiate with hypertrophic cardiomyopathy. By increasing the intrathoracic pressure, it will briefly decrease the preload and also decrease the afterload. As a result, we're going to get a reduction in the murmur due to the changes in flow within the heart. Hopefully that makes sense to you. Well, I hope that's been a reasonable overview for you of the pathophysiology, the etiology, and the clinical examination with regard to aortic stenosis. I would strongly recommend you to really read about aortic stenosis, how it affects patients, and simply understanding the hemodynamic changes with it. This is the commonest murmur, and if you can grasp the basics of aortic stenosis, it'll give you a big grounding to look at other murmurs as well. With that in mind, I hope this has been a useful video for you. Please consider liking and subscribe to the channel, and perhaps if this one has been of benefit to yourself, we'll do further deep dives into the other cardiac murmurs. With that in mind, take care, and I'll see you in the next one. Cheerio.